President of the Republic of Ghana appointed Dr. Akambong as the Acting Director General of the Ghana AIDS Commission, entrusting him with a critical mandate of leading Ghana's national response to HIV/AIDS. In this role, he spearheads policy development, prevention strategies, treatment programs, and stakeholder engagement to achieve epidemic control. Prior to this appointment, Dr. was a senior lecturer at the University for Development Studies, where he trained and mentored numerous medical professionals while contributing to pioneering research in infectious diseases, cardiovascular diseases, gastroenterology, and hospital management. His work has been published in esteemed medical journals, and he has presented at renowned global conferences, including the American Association for the Study of Liver Disease and the European Society of Cardiology. He also played a transformative role in Ghana's healthcare system, serving as Chief Executive Officer and Director of Medical Affairs at the Tamale Teaching Hospital, where he led a major hospital modernization initiative, improved healthcare delivery system, and introduced advanced medical procedures that enhance patient outcomes. Under his leadership, the hospital expanded specialist services, improved emergency response systems, and strengthened partnerships with international medical institutions. With a passion for public health advocacy, medical education, and healthcare transformation, Doctor remains committed to shaping policies and strengthening healthcare system in medical research for healthier Ghana. Doctor, you are welcome. Doctor holds a lot of degrees in all spheres of health. Doctor, I can't even talk about your profile enough. You are welcome, Doctor.
Thank you very much.
Thank you very much.
Thank you very much.
You're most welcome, Doc.
Thank you very much.
You know, when I read your profile, I was like, hey, how do I summarize all these things? Hey, Doc, you are doing very well.
We have a way of putting plenty things that could have just been said. So
maybe I have to learn how to do a summary more.
Thank you for the opportunity. Thank you.
Yeah, and congratulations. I haven't met you to congratulate you after His Excellency gave you that mandate.
Thank you very much.
Yeah. So we are talking about prevalence of HIV in the country. Even though people have done a lot of things to curb the disease, to talk about it, and also make people get to know it, to test and all that, still we are getting a lot of increase. Why is it so?
Thank you very much for the opportunity. And let me just say, by way of historical background, that this year is 40 years of HIV in Ghana. 40.
Wow. Wow.
On the 26th of March this year, we marked the first 40 years of the first detection of HIV.
HIV case.
In Ghana.
This cannot be celebrated. Hooray.
It ought to be celebrated, but in Ghana, we made so much gains in our response to the disease. But typical of we Ghanaians, soon as we are beginning to get something under control, we take our eyes off the ball, and then we start getting resurgence. And it is this resurgence that we are worried about currently, and thinking that we need to step up our game. Whilst observing the 40 years of the epidemic in Ghana, we also have to re-examine how we can make bring the disease under control. As you said, our national prevalence as a 2024 data. In about a few weeks' time, we'll come out with the 2025 data. We're working with the 2024 data. Our national prevalence for adults living with HIV is 1.49%.
1.49%. That's about 300 and...
So in real terms, it's about 334,780 people living with HIV/AIDS.
That's a lot.
That is a lot. And it's unacceptable. We have to
and these are even people who have tested.
These are people who are in population estimates. You know, we do the estimates based on population data as well as programmatic data.
Right.
When you take all these projections, you would see that based on what we have on the program and based on what we have tested and other surveillances, when you project it to a group of the population, then we are having 1.49% of our population living with HIV/AIDS.
That's a lot.
That's a lot. And surprisingly, if you take the 334,000, over 334,000 people, 5 regions contribute the greatest of the burden across the country. And maybe as we go into
Greater Accra.
Greater Accra, of course. Greater Accra alone has over 77,000 people with HIV.
Hey!
Telling you, frankly. And they are concentrates, like you can have geographic concentrates on most of these prevalences. Yes.
So we are going to look into all these.
We're going to look into all these details.
Wow.
But I would say that over the years, we started with a prevalence well above 4.2%, and then we've been able to bring it down all the way down to 1.4%. But the rate at which we are bringing it down, it's not that encouraging.
Is it possible we can have 0%?
We are unable to have 0% prevalence, because that means that everybody living with HIV/AIDS would have been treated fully, or we have a treatment that can cure it, or everybody living with it has died. So we can't have.
We can't have, but it can just go down.
It can go down to where we get to a point we say it is of no epidemic significance.
But at the point, it's still...
Yes, 1.49 is still.
Which is
because
high.
when we come to look at the new infections, we tell you that there are still gaps for us to work on. And looking at the deaths too that are also occurring with HIV/AIDS, and the treatment cascades that we want to get to, there's still a lot of work to be done. Yes.
Wow.
So the last prevalence was 1.52. That's 2023. 2024, we're able to bring it down a little bit to 1.49. Yes, when the new data comes, we made some gains, especially in...
Have you come across it before it's published?
Yeah, so we are there is an international validation process of the data.
Okay.
The data is ready, but it has to be validated on international platforms before we can bring it out.
But does it look positive or negative?
It looks good.
Looks good.
But we still have some work to do, especially the age category that we're getting.
Which we are getting the incidents.
Yes.
So what's the previous year? That's 2024. What's the age category?
So
do they have any difference from this last year's?
Yes, we have seen some reductions in the age category, 15 to 24.
Yeah.
They're very marginal compared to the other categories, 15 and above to 70 something. But if we do the segmentation and look at the new infections within the segmentation, the age group 15 to 24 years still has high prevalence, almost up to 30% of the total new infections.
That's too much.
That is a lot. And we can look at the reasons for why these new...
What are the reasons?
The reasons are varied. You remember when you and I, as doctors growing up, I mean, there was a lot of information on HIV/AIDS. Open every radio station, there are...
Singing, talking,
the A, B, C, D, all those ones. There was information, education materials available everywhere. There was a lot of public health campaign on prevention. Yeah. So the focus was on prevention. Maybe what we didn't do right with prevention was creating fear around prevention. And that fear created some amount of stigma that has lived with us up to date. But that information was very good for people to pick up for the uptake of the message. Yeah. And people really took up the message. And then a lot of people got to know that the disease was there, how to prevent it, preventive mechanisms were all available. However, with the discovery of treatment, a more effective treatment, programmatic directions move towards putting more emphasis on treating the people who have the HIV/AIDS, so they don't die. Yeah. And then we lost focus again on the seriousness of the preventive messages. So if you take any age group of 15 years to 24 years, they will not have heard what you and I heard years ago,
about 20 years ago.
About 20 years ago. Yeah. And they are the ones who are now coming up with less knowledge about prevention, and whose lifestyle, you and I know, are quite complicated. Because their communication channels are quite not the way you and I know. These are about social media people who know how to communicate through social media and other aspects of media, not the radio and the TV and other aspects that you and I have been grown up with. So that is where the information gap has come up to.
Wow.
Yeah.
So, but can you tell us about the regions? You mentioned that it's categorized in regions.
Yeah.
So which region is the highest and then goes down?
So if you take by way of absolute numbers, Greater Accra has the greatest number, about 77,000 above. Ashanti region follows immediately with over 66,000 of people living with HIV/AIDS, followed by Eastern region, and then we have Western region, and Burn-Half now it used to be Nambono region, and then Western of. They are the 5 regions that lead.
But why?
And if you look at these regions in particular, and especially if you correlate that to new infections, something is coming. You can see something. These are the regions with a high amount of extractive industry.
Okay. Actually, I was going to ask you.
Yes.
Yeah.
They have the high prevalence of extractive industry. And you know, the extractive industry draws young people to the environment.
Yeah.
It creates some form of trade that goes on there. And that is where young people aggregate. Then other vices also would follow, including unsafe sexual practices. Especially if you look at the extractive industry, where the unregulated extractive industry environment, where the use of other drugs are also prevalent. And if you follow the illicit drug use landscape, you would see that in these areas in particular too, there's a high prevalence of use of illicit drugs. And therefore, these go with irresponsible sexual behaviors. And of course, people also go to have all forms of trade, and then the prevalence would also go high there.
But what contributes to this widespread?
What is a lack of knowledge, first of all, and the fact that people are skeptical to test. And I would say, if you test to know your status, it's power. You protect your status.
You should test it.
You should test and know. And once you know, you protect it jealously, so that you don't take.
Do you think it's very easy to just walk to the hospital to test for HIV?
Yes, so that is why the Ghana AIDS Commission, alongside its stakeholders and other partners, we are trying to bring testing to the doorsteps of individuals, because we are now emphasizing on self-testing, where you can take this test strip, get to the comfort of your room.
So like the pregnancy test, kind of malaria.
So like pregnancy test, malaria test. So you can have it self-test mechanisms, where you just take the test kits. Sometimes you get home, you may not have the confidence to test. Once it's with you, one day you just
can't just get up.
Let me just get into the washroom and see what I do. Do the test and then get to know your status.
You just close your eyes, do the test
take
quickly.
That confidence in you to be able to just undertake it. And then once you're able to get to know your status, you protect your status.
But why is this so scary?
It's a stigma, and stigma and discrimination. You can imagine that you can be sitting with friends and colleagues having good discussion.
Yeah.
The moment you disclose your status, then everybody says, "Oh, why?" It's like the people begin to shun you, and that kind of discrimination is what makes a lot of people unable to test. And that stigma makes people to have two forms of stigma, because you are shunned. You eventually get to what you call an internalized stigma, where you yourself haven't got the confidence enough to be able to stand up to go for treatment or take other services that are available for people living with HIV/AIDS. Now, then the society stigma is also there as well. And if you take the society stigma, people get withdrawn, they don't want to go to service centers, and therefore they just stay where they are. That becomes a background from where people even transmit the disease further. Because if you don't go for treatment, you are likely to transmit the disease. And if you take the fact that current treatments are so effective to the point that people can get to the point where you can detect the virus in their system. And in fact, if you look at the statistics, in the treatment cascade, as we'll come to talk about treatment cascade, 90% of those who are effectively taking their medications have reached a level that we can't detect any virus in them.
Wow.
Yes, that is where we are. So the aim is to get as many people on treatment. But if you don't fight the stigma issue and allow people to take self-testing or voluntary testing or even testing as part of a routine process, then we cannot get to this 95.
We'll talk about the treatment.
Yes.
But we were discussing why the spread.
Yes.
And you said because they are not testing. We are not testing.
Yes. And of course, the other preventive mechanisms are also not being used. The use of condoms. So you see, I'm wearing a shirt. Just use it.
Let me see that.
Wear a condom.
Let me see that. just use it. International Condom Day.
Yeah.
But that was in December.
Yes.
Oh, okay.
So we want you to use a condom.
Okay. You should have brought a T-shirt for us to wear together and we'll twin.
I'll bring a lot to Joy for so that yeah, but that's what it is.
Yeah.
The use of condom has gone a little bit down. And people, when you talk to them, it's not so natural. They want the natural feel and all those ones. And then more so, if you look at the condoms that are in the programmatic distribution, they say they have been given various reasons over the years why they have not used it. They are inferior, they are thicker, there are a whole lot of complications, they are smaller, all sorts of explanations. But you see,
talking about the size. Talking about the size,
okay.
DJ. Would you consider the size of the males? The males, men in Ghana, and then
yes, these are all in consideration because
you can't pick the size of
the national
India,
condom program. The national condom program that we have is based on feedback.
Yeah,
the feedbacks we get from every 3 to 4 years we do a condom strategy.
Okay,
condom and lubricant strategy. Based on those feedbacks, then we put that into the next procurement process.
Okay.
Yes. So so
you got a feedback that it was too small.
Yes. So we have taken care of that, and then the thickness too. We're also looking at the next round of condom processing, procurement processing. To cater for.
Are you taking into consideration the brand, or you put standards there for anybody who is importing?
So what we distribute for free is unbranded.
Unbranded.
It's unbranded. Okay. Yes. But of course. The next condom and lubricant strategy would also not mind bringing in some branded condoms, but they have to be for free.
Okay.
You can't brand and sell. If you're ready to bring your brand and give it and let us be part of the program, it should be for free.
But I was thinking that you would put some standards so that anybody importing a condom could look at those standards.
The Food and Drugs Authority, they have standards for those.
So you can do a collaboration based on your feedback you are getting.
Yes. So the feedback with the international standards is what we give to the procurement.
They are small.
Oh, they are okay. They are okay for Ghana now. Yes. What is not has not been in full circulation is the female condom.
Yeah.
Yes, because initially its use was a bit cumbersome.
Yeah.
Through the feedback, we got that feedback and made more user-friendly female condoms.
Okay.
But of course, the outlet distribution has not been that as we want to be.
Okay.
So you may always get a few shortages here and there about the female condoms.
So you have improved upon.
They were not even available in the system.
Yeah.
We're now getting them back into the system.
Oh, so you mean you have improved it from?
We've improved from the previous initial feedback that we got.
Okay.
Yes.
So what's the new one? What's new for us?
Oh, it's very user friendly.
Okay.
It's very convenient.
Okay.
And it's very fantastic.
I'm sure you bring a sample for us to look at it.
On the Ghana AIDS Commission website, there are always demonstrations of.
Oh, so we can go there and check.
Have a look at how the demonstration.
Okay, they're on your website.
Our website as well.
Okay. So that's fantastic.
Yeah, so and that's one of the reasons. And one of the reasons you asked for why the increase in effect spread. You see, sometimes if you look at the young generation, there are all sorts of things.
Yeah.
People go for sex parties, they go for all sorts of arrangements. But of course, that is not usually taken into consideration that I may falter in what I do.
Yeah.
So what we call pre-exposure prophylaxis services.
Okay.
Where as you're going for a sex party, you will think that, oh, I could do something wrong. When you take that prophylaxis, should I do something wrong protected? Or even if I do something wrong, post-exposure prophylaxis, what you and I know in clinic, if you get a needle stick, for example, go for post-exposure prophylaxis. These are the services we need to ramp up and let people know where they can get these services. So that should you get into a very unsafe situation, encounter, then you can call a center nearby, say, look, this is what I got myself to. Have yourself tested. If you're negative, you go through the full spectrum of post-exposure prophylaxis. These are ways that we can reduce that. And
can they just go to the hospital?
Yes, you can do so, and you must, if you demonstrate reasonable grounds for which you want to take post-exposure prophylaxis, then they will let you take the test and provide it for you.
Then people come every weekend or every week? Do you have
that is why we have demonstrable reason. It can't be that is your lifestyle.
Yeah.
Get to know that pre-exposure prophylaxis is available for certain vulnerable classes.
Group of people. Yeah.
Commercial sex workers, for
yeah.
example. And other people who are also in very difficult, vulnerable situations. They can't bargain safe sex for themselves.
Yeah.
So it's also available for them as well. Okay. Especially the AGY, the adolescent girl and young woman category, who just can't bargain safe sex for themselves. Pre-exposure prophylaxis is available for them as well.
Okay.
Yes. And also for intravenous drug users who are more like who can easily transmit it. It's also
through that,
and certain key populations as well.
Like?
They're all key populations.
They are all key populations, yes.
Yes.
Yeah. So let's look at this.
The data.
The data.
Yes.
Talking about from.
So you see, Greater Accra 77,800.
So this is 2024.
Yes.
Okay.
And by the end of July, we'll come out with the 2025 data.
Okay.
That would have gone through the international validation process by the UN.
Does it look so different from this one?
It's what will be different is the new infections.
Okay.
And then the national prevalence, which I say has come down from the 1.49. It's much better now.
So this is the incidence rate.
So this is the incidence of new infections. So of the 15,290 new infections in 2024, Greater Accra alone contributed 3,436.
That's a lot.
That is a lot.
Yeah.
Followed by Ashanti region of almost 3,000 new infections, 2,000.
New people who have been infected.
You have infected. And then Eastern region, you have 2,019. Central region, 1,140. Western region, 1,120. But if you take regional
I think we have to go and stay at northeast. Because that is so small. But even though it's small, there are people there who have been tested positive. So
it is also and get to know that these are the index testing that's for the year.
Right.
And people live the disease for a long time before they actually show signs. If you look at the fact that these Greater Accra may have the highest new infections, but you come to the regional prevalence by region, Bono region has the highest prevalence. Yes.
Bono region, Techiman. That's Sunyani. Yeah, Sunyani, right.
The national prevalence is 1.49. Bono region has 2.2%. Know that the prevalence is number of people living with it against the population. So if you have a certain number of people in the population, not that much, then the prevalence may be higher. Though the numbers are greater in Greater Accra, but the Greater Accra is big.
Yeah.
The numbers are big. So the denominator
caters for this.
So that is why we have. But we are intensifying our efforts in the Bono region because for the past 5 years, it has been the region with the highest prevalence. 5
years?
Yes.
But that place looks so peaceful.
And quiet. The storm below the quiet. So these are the things that these services as we're talking about.
So as you said, these are the adult HIV prevalence figures.
Yes. So the 15 to 49. So if you take Bono region 2.2%, Eastern region 2.08%, Ahafo 1.88%, and Greater Accra 1.80%.
But this could be because of the denominator.
The denominator, as I said, yes. Yeah. But Eastern is also quite populated, and to have 2.08 quite tells a lot.
Yeah.
Yes. So if you take the Bono is Bono and Ahafo.
We need to do a lot of.
We need to intensify this because there are a lot of commercial centers to us. That's the Chima Market.
Yeah.
And the other miners area. In the Ahafo area, there are new mines and a whole lot of things that are there.
Yes.
So these are the things.
TJ, you have a lot of work to do.
We have a lot of work to do.
Yeah.
Especially bringing down the existing new infections, bringing down the overall prevalence, and bringing people up to treatment.
Yeah.
That's the most important thing. So the new prevention strategy is vamp up testing, including self-testing, index testing, differentiated testing, all sorts of testing. We want to vamp that up.
Yes.
So that if you look at the WHO UNAIDS targets, that we should have 95. And I'll explain that. 95% means that 95% of all people living with HIV/AIDS know their status. We projected that the prevalence is 1.49%. That gives us a national projection of 334,000 and above. 95% of those people should know their status.
Okay.
And 95% of those people who know their status should be on treatment. Okay. Then we should have to get 95% of those on treatment to reach viral undetectable levels.
Okay, so it means you're just taking care of the 5% margin of error.
Margin of error.
Right.
It is at this level, when we get to this level, then we can be getting close to epidemic control. I know that epidemic control is where you have very low levels of new infections that are continuously going down, but you never get zero because of the disease. And the deaths are also
reducing.
Yes. So that's what we get.
Is it doable?
It's doable. In fact, our target is 2030.
2030?
Yes.
We have 4 years.
We have 4 years to go. That means that we have to ramp up the throttle to be able to reach these targets. And it requires a lot of work and a lot of financing, especially in this landscape, this period of landscape where funding is going down.
Yeah.
We're just talking a while ago about the absence of the U.S. funding in this landscape.
Yeah.
It has taken a lot of toll on all national responses.
But as a country, can't we generate some kind of funds towards such a thing, DJ?
Yes, we have developed a long-term sustainability framework, how we can take control of our own national responses.
Yeah.
The Ghana AIDS Commission has developed the sustainability roadmap, and part of that has many components. Integration. You know, the Global Fund takes care of 3 diseases: malaria, TB, and then HIV. How do we integrate them into each other as a response, collective response, and also into our national healthcare systems instead of standalone interventions? And that is taking place because the primary healthcare is one of the mechanisms through which we can do integration. Yeah. And through that, even the clinical aspect of this disease can be integrated into the National Health Insurance Scheme. For example, if you go to a hospital and you have a diagnosis put there as HIV or AIDS, it is not under what we call diagnosis-related groupings, where it can be costed under health insurance to get treatment. But if you go under opportunistic infections, then the opportunistic infection is treated. Yeah. Not the main cause. So we've had this discussion with the National Health Insurance, and we are doing that integration. And the actuals have been done, and we're just getting to the point where we agree on the levels of the integrations and the services that are covered, and then we roll it off as part of the integration process. These are things that were as part of our sustainability roadmap. We're also looking at an investment case where we think that by the act establishing Ghana AIDS Commission, there's supposed to be a national HIV/AIDS fund. Yeah. How do we get that fund to run? How do we grow the fund and mature it to a point of sustaining our national response, or other mechanisms of financing, right? Whilst waiting for the fund to be built up. Like we can use we can go to other ways, but we have the District Assembly Common Fund, where 0.5% of the District Assembly Common Fund is to be given to at the district level for HIV responses. How can we decentralize these responses to the districts and make them also own part of the funding processes of the national response? These are the things that we are discussing.
But are there any emerging trends of HIV cases that are of interest to the Commission?
Yes, the emerging trends is the 15-year to the 24-year, and that is very much of.
That's the core.
That's the core. Yeah. The core of everything. It's the core of our future generation.
Yeah, exactly.
It's the core of our workforce. Yes. It's the core of our moral upbringing. And if we don't take care of it right now, the future workforce will be affected.
Are these
having this in mind?
Males or females?
So or both? Yes. So let me tell you the preponderance. Generally, there's a 3-to-1 preponderance, male to female. So females we have more prevalent females than males. In almost all the categories of the age group categories, you will see that twice as more females are affected. I will come to elaborate more on that. So it doesn't look like it's a gender issue. Yes, but as I indicated, because we're looking at this future workforce, and current workforce, the Ghana AIDS Commission, together with the Ministry of Jobs, Labour and Employment, developed the Workplace HIV, TB and Wellness Policy. Right. Which was just launched about 2 months ago. And that is to take in focus that HIV and TB are very important workplace issues because of the stigma and discrimination aspect of them. Right. We are integrating that into the workplace wellness, which includes screening for cardiovascular disease as well as non-communicable disease. Yeah. So that the workplace owns all this. All these. Mental health, very important. So in that document, that policy, or that is all part of it. It's a collective document, policy, where mental health issues within the workplace are looked at, non-communicable diseases are looked at, HIV and TB in particular, because of their discriminative nature, are also part of that, because workplace discrimination can lead to low production, can lead to worker dissatisfaction, and even anarchy within the workplace. So we looked at this, and then we launched it. So when is it going to be launched? It has been launched already. It has been launched? Yes, okay. It was launched in April. Okay. Yes. Okay. There's a task force. We're getting TUC, the Ghana Employees Association, Ghana AIDS Commission, Ministry of Employment, create a workforce to do a regional dissemination of this, this policy. When is this going to be? We're looking for funds to start that. You know, a little bit of money will help that. But the general female preponderance I was talking about, it's not just a gender issue. Okay. Because if you look at the testing, self-testing, and the testing cascades that we do, females are more likely to do testing than males. Yeah. Our problem in Ghana is that there's a low level of male testing. Not in Ghana. It's a global problem. Males do not like to go in. Yes. So there's a low level of male testing. And if you see some of our surveillance mechanisms, where we use pregnant women when they go to antenatal with tests. Exactly. So almost every female who is pregnant, who comes gets tested, has been pregnant or is currently pregnant and they're going antenatal, so will get tested. Yeah. And therefore we get more testing within the female category. Yeah. And the more you test within a certain gender group, the more you get the results there. It isn't that. So it means that there are a lot of males who are in the hidden population. There are a lot of males who are in the hidden population. Of course, we as doctors, we understand that once the male deposits the sperms there, it comes with all the virus and everything, and the female just becomes a receptacle. Yes. You understand? And the male has to have demonstrable breach in skin and other conditions to be able to have infection. That is where the risk is much higher. Yeah. So the biological nature. The biological nature of the anatomy. Okay. Anyways, okay. So we'll go on a quick commercial break, and then when we come back, we'll discuss the treatments and then stigma, discrimination, and all that. Because I heard you mention a few things about treatment and some good news out there. Yes. So I would like you to share with us. Okay. Yeah. Right. So we'll go on a quick break. Stay tuned, don't go anywhere, we'll be right back. Welcome back to Consulting Room 5 with me, your host, Dr. Sue. We are discussing HIV prevalence in Ghana, and we are with Dr. the Director General of Ghana AIDS Commission. I nearly gave you a deputy. Don't make my way less now. Anyway, have you heard about the new pepper in town? Kivo hot pepper is the new pepper. It is now easier and faster to cook those spicy, delicious meals you love with Kivo hot pepper. You will feel the heat and delicious taste in every meal made with Kivo hot pepper. Get yourself some hot pepper today. Use it for your noodles, spaghetti, shitos, stews, soups, you name it, and just thank me later. It's available in various pack sizes that is convenient for home cooks, chobbers, restaurants, student use, and many more. Kivo hot pepper. Mokusho. Doctor, this HIV thing,
The stigma is too much.
Stigma is a big problem. Self-stigma, stigma from the community.
Even the service providers.
Yes, so health worker stigma and discrimination is a big issue. We've looked at data from other countries in Africa here. The biggest issue we have is the health workers stigma. And they stigmatize the patient right from the onset, from the moment they get to have the patient's biodata. That has made a lot of people to shun away from coming to
the hospital,
health centers, provision centers.
Yeah.
And despite the years of continuous training of people in that area, it just gets to a point where as other people retire from the service and new ones are coming, it doesn't get inculcated in all health workers that there is an amount of confidentiality in dealing with the biodata of people with HIV/AIDS. And if your health worker would stigmatize you, who else can you go for?
Exactly.
And then you come back to family. Family stigmatizes you. This community stigmatizes you. Society stigmatizes you. You just go into a self-induced stigma. You just feel you're not worth it. Start accusing yourself for things that you didn't have much control over. And that is where we lose a lot of patients too.
Yeah.
They recoil because of stigma and discrimination. And these are people who should have been out having treatment and living God-given years life. And frankly, if you're on treatment, nobody can go and point at your face and say you have HIV, you have AIDS. The medications are very, very effective. Talking
about treatment, what are the available treatments for us, for people living with HIV?
So we have the antiretroviral medications that are available at the antiretroviral treatment centers, the ART centers, and they are highly effective. We have various combinations for various types of people. There's what is generally available for the pool, and there's also what is available for specialized categories of people, especially those who have other co-infections like hepatitis B or C, or they have renal failure, or they have liver disease issues, or people who are undergoing dialysis and other conditions as well. So yes, there is a wide spectrum of medications availability for every category of patient, including pediatric patients where the syrup preparations are available for use for young children who cannot take the tablets. And they are very effective. And
can they go to any of the health centers or facilities for such treatment?
It must be a registered ART provision center. If it's registered, then they should be able to provide those centers. We also have other civil society organizations that work with some of the program managers, like the National AIDS Control Program, who are able to go into community for community distribution of the medications. Because sometimes, take a place like difficult to reach places. In fact, in my nationwide tour, areas like the Western North, they are very, very difficult to reach areas.
Western North, we are also BBNE.
Have thick forests.
Yes.
There are communities that are deeply embedded within the forest community, the forest zones. And therefore, we have some of our civil society organizations that are able to drop medications at these places for people to take. Yes. Because it may take the person about 2 or 3 days to travel from that place to the nearest ART center. And they go into interlands to identify these places and drop medications for them periodically, for them to take. And they have community support systems within those areas where it is difficult to reach. Yes, so the medications are effective. We are able to reach many people for treatment. What we need to do, as you and I were discussing, and which is a national issue, is a young generation of people who will not just want to say, where do I go to ask for these medications? We are not trying to develop we're developing some AI systems and the platforms where if you just type, where is my nearest ART center? Then it can tell, just 3 kilometers from here, around the corner here, the location, and you can pick it up. We are developing that with some of the in Brazil, as part of their 40-year celebration, they developed a chatbot that allows young people to be able to access some of these preventive services, clinical services, and other support services as well. So we are looking at that as one of the way of our prevention strategy. But of course, the medications are very, very
you are even saying that people can just take it and then about 95% of the virus may leave the system of the blood.
Even for those who are taking it, with our cascade that I mentioned, that Ghana, we have 90% of those who are on the medications who have their viruses and you can detect it in their blood. You understand? Why not 100% of those who are taking it?
Does it mean that they wouldn't have the virus in their blood again?
By the mechanisms available for testing, we can't find. But we can't say the virus is not there. Okay. Therefore, they should stop. You know, there are sentinel areas in the body where the virus can still hide, like the lymph nodes, sequestered organs like the testicles and ovaries. They may still hide there. Yeah. So if you stop them, there may be a resurgence. Okay. So, but if it's just blood circulation that you take to look at the system that tests, be it
it may come as negative
PCR, you won't find any level there. But they are still sequestered in other areas, and that is why we feel long-term treatment may also lead to what? Eliminating the virus in these sequestered organs as well. Okay. Yeah. So that's why those even get undetectable level, we encourage them, don't stop taking, keep taking the medications.
So even when you are taking and then you do a test and it's test negative, continue taking it.
We encourage you to continue taking because the virus may be hiding somewhere.
The virus that is hiding somewhere, can it be transferred to?
No,
is it communicable?
It must be in the body fluid system. Okay. Once it's not in the body fluid system, it can be transmitted. Okay. But it can resurge, if you stop the medication, it can resurge back into the body fluid system and becomes transmittable again. Okay. And that is why we say that once you've been able to treat it to where it has gone to hide itself away, keep the treatment there and don't let it come back to the blood.
It means you are taking it for life.
One day, you may just not need to take the medications anymore. Yes. Probably get to that day one day. Yes. Okay. But also new in the prevention effort is the introduction of the injectable medications that prevent you getting infections. Okay.
And usually, is it like a vaccine?
No, it's not like a vaccine. Okay. You know, you and I know the mechanisms by which vaccines work. Vaccines would usually stimulate the immune system one way or the other for it to work. This is a drug that prevents the integration of the medication into the immune system where it affects it. Okay. So it prevents the virus from becoming as part of your system, and therefore it dies off. Okay. And once you take that injection, 6 months, you take a booster again for a whole year, you are covered 99.5%. You can't get the infection. It's called lenacapavir, and you referred in the media and the news that some African countries are trying to roll it out. Nigeria, South Africa. South Africa actually had a license from the company that makes it, Gilead, for local production of the medication. In Ghana, we as part of our prevention strategy, it will be part of the next year, 2027, roll out of the prevention, starting with the key populations.
Is it going to be free?
So if it comes under programmatic funding, it will be free. So we'll start first of all with the key populations, like the female sex
vulnerable group
and other vulnerable groups, where we will let make it available under programmatic arrangements. But of course, if you look into the general lifestyle of most people in Ghana, people fluctuate from vulnerable population to non-vulnerable from time to time.
Coming back, depending on your situation.
Depending on situation. Yeah. So it's on case-by-case basis. Okay. You have to evaluate that and see.
So this thing, it means it will be taken annually?
So two injections annually.
2 injections
One injection, and then 6 months you take a booster, and then you are protected for a whole year.
For a whole year. So you take your 1 year protection from HIV.
1 year protection. Yes. Yeah. It's not, as you say, it's not a vaccine, it's a medication that is protein bound and stays in your body for a long time. Okay. That's why it can do the work it does over a whole year.
No, don't you think when you bring it, people will be so excited about it and be too promiscuous and bring in other viral infections?
No, that's why it has to be there should be guidelines for its use. if you don't use guidelines for the proper use of the medication, it can be abused. The tendency for abuse is there because
so high.
I mean, everybody. So why don't I just take the medicine and forget whatever I do?
Exactly.
No, there must be guidelines for its use. And then if you qualify under the vulnerable population, for example, if you can demonstrate that you are a serial monogamist, for example, then, and it's demonstrable, we can look and say, I mean, by the lifestyle this person lives, it's a vulnerable population. Then,
okay,
yeah, you can be under special dispensation allowed to take the vaccine. But
this
of
is
course,
going to be interesting.
Yeah, it has to be very, very programmatic before it becomes public and everybody's rushing to go. Yes, it is available in the US in public use, but it's quite expensive, over $22,000 a year of injection. But if it comes in a program, it's likely to be highly, highly subsidized. Yes.
So, but which other preventive strategies do you have as a commission?
So I was talking about our condom and lubricants strategy.
Right.
Yes, I indicated.
Right.
You know, we are just about to launch that strategy after evaluating the previous strategy. What we want to do is to make sure that we have condoms readily available in public use. You know, the buying of a condom too is quite stigmatized.
Yes.
Walk to a chemist shop or a drugstore to buy a condom, and then say, I want a condom, and everybody raises their head to look, who is that who asks for a condom? And then you change your mind and you don't want a condom.
Buy the paracetamol.
You buy a paracetamol that you didn't intend to buy by force. So that is a way that we want to make these condom vending machines. Once upon a time, Ghana AIDS Commission had them in most of the public spaces. The transport stations, lorry stations, stadia, nightclubs, and many places.
Right.
But they broke down because of the fact that, you know, you have to put a 50 peso coin to get a pack of tray. The coins build up, and somebody is on drugs, he needs those coins to buy drugs. It
breaks the coin.
Breaks the machine, takes the coins, and then the machines over the period have become defunct. We are looking at with best practices how we can do it jointly.
Right.
You can also have the female condom distribution mechanism.
Okay.
Have the male condom distribution mechanism.
Okay.
Then you can also take a test kit.
Hey.
Yes, a test kit.
Okay.
To do the self-testing, where you can go to your room and do a self-test. Now the earlier structure was that you could use a coin and pick the condoms. Then somebody goes with 20 of the 50 peso coins and empties the machine.
Oh.
And then other people need it, they can't get it. So we also have to put a limitation to number of condoms you can have at a particular time. So these are the things that we're looking at to see how it can reach the general population quite effectively.
It sounds great, though.
Yes.
Yeah. So, DG, what's your final words for our viewers? What advice would you like to give to the viewers about the prevalence? Telling us how high it is, especially in Greater Accra region and the other regions. What advice, the final words to my viewers?
I want to tell Ghanaians that HIV is still in the system. It is not gone as people may think, because so much noise has not been made about it doesn't mean it's not there.
Yeah.
It is prevalent. It is a threat to public health systems. It's a threat to our workforce. It's a threat to our communities. There is so much power in knowing your status. When you go to test to know your status, you protect it jealously.
Yeah.
You don't
jealously.
Yes.
Right.
You don't only protect yourself, you protect your community, you protect your family as well. And I want to encourage people to get to know their status.
Okay.
If we had gone deeper into the statistics, in 2024, over 12,000 people died from HIV/AIDS.
Oh.
That is a lot. And it's good to get to know your status, because most of these people who died only came with extreme complications and refusing to know their status.
Okay.
And then they got to a point where they could not be redeemed medically, and they died after that. Whether you test to know your status or not, when the complication will bring you, and that is a point where when it is revealed to you, it becomes even more disgraceful than if you are taking the test much earlier and taking control of yourself. So please, test to know your status. There are effective treatment mechanisms. HIV is an ordinary disease. Let us not stigmatize it. There are some certain categories of disease. If you put HIV here and put those diseases there, I'll pick HIV if I don't have a choice.
Hey.
Yes, because I know I can live with it.
Right.
I can treat it. But there are certain cancers, for example. If they say take this one and I'll prefer to take the HIV. And that's if we can accept to take certain disease. Why
can't you
take HIV?
Take HIV.
And take the test for it.
Yeah.
If you as a man can go to test for prostate cancer, or to test for HIV.
Right. Thank you so much, Dr. Akanbong. The G, I want to let it come out very well, Dr. Akanbong. Okay.
Thank you.
So, thank you so much for honoring our invitation. Get tested. Early treatment will save your life. Don't hide in there. Don't think that it's better for you to keep it. If you keep it in there, the disease will take you to the clinic. So go to the clinic, get tested. There are a lot of treatments from doctor. He has said that you can have a lot of treatment, and at the point you can even not have a strain in your blood. So get tested. Early detection saves life. Be bold, get tested, and also when you get to know your status, you protect it jealously from doctor. That's what he's saying. So thank you so much for having me, Consulting Room 5, with me, your host, Dr. Sue. Enjoy your week. Always stay blessed and stay safe. Get tested. Bye.
Police station. Na traffic light no be say na say. Ko ndi how you papa. How you papa na. Sa traffic light na say. What you ni na won kese fi we be di mira so.